I would like to thank the organisers for inviting me here this morning. It makes, I should say that I am a chest physician and an epidemiologist, and it warms my respiratory heart to see so many people in diabetes who are interested in the lung. I should also say I don't have any financial disclosures, but that's not to say I'm not open to offers. So if I take you back to your training at medical school or in other aspects of medical training, and you think about lung fibrosis, these were probably the things that you were taught. You would think about asbestos, not so common a cause of lung fibrosis now, because most of the exposure levels have gone down. You might think about infection, smoking, radiation, either medical or radiation from other sources. You'd think about connective tissue diseases, rheumatoid arthritis contributing most cases of lung fibrosis, but in relative terms, scleroderma gives you the biggest risk. You think about drugs, amiodarone, and my personal bugbear is nitrofurantoin, which keeps coming back into circulation and which repeatedly causes lung fibrosis. You think about sarcoid, here's somebody with sarcoid, and you might think about bird fancier's lung. So all of these we know are causes of lung fibrosis, but that's not what I want to talk to you about today. I want to talk about idiopathic pulmonary fibrosis, which is a disease I've spent 25 years looking at the epidemiology of, on and off. And what I'd like to do briefly is talk a little bit about what it is, and actually if you went to the equivalent respiratory meeting, we spend days talking about what it is, how you might diagnose it, how common it is, who gets it, what the cause of it is, comorbidities, and I've tried to slant this as much as I can towards diabetes. So what is idiopathic pulmonary fibrosis? Previously in the UK we used to call this cryptogenic fibrosing alveolitis. And again, you may have come across this perhaps in your medical finals, and my tip to all medical students is in the respiratory station in medical finals, at least half the cases have got IPF, because they reliably have got good clinical signs. And when you listen to their lungs at the back and at the bases, they have lovely crackles, which is said to sound like Velcro being pulled apart. They are mainly older people, and they are mainly men more than women. In the textbook it will tell you they are clubbed. In fact, not that many of them are clubbed. Way under half are clubbed. You will hear about, you've heard already about lung function. That cheered me up as well. And our belief is classically people who've got lung fibrosis have restricted lung function, so they have small lungs. In reality, simple spirometry is not always great for people with lung fibrosis, because about 70% of 70-year-olds have been smokers at some point, so very common to have mixed disease, and often you'll find the airways disease will predominate. So don't be put off making a diagnosis if you don't have restricted lung function. Very good. You've heard about 6-minute walk tests. They're extremely useful, and actually in clinic I don't even bother with them. I just put a saturation monitor on people and walk them up and down and see what happens. But there's no doubt what has changed the management of this condition, and what came in the early 1990s is CT scans. And what you find in CT scans of IPF is the disease you get will start at the top here and run round to the back. And you mainly find it at the posterior bit, at the basal bit. And you get this sort of looking a little bit like an aero bar, or you get honeycombing at the back and at the bottom of the lungs. And that is very characteristic of idiopathic pulmonary fibrosis. And it's been pointed out to me, I did a number of studies looking at occupational exposures. Most things that you breathe in and that are cause of lung disease affect the lung at the top. TB, pneumoconiosis, those kind of things. The bottom of the lung, if you remember your physiology, it's characterised by having more circulation proportional to its ventilation, just raising the suggestion that maybe this is a blood-borne problem. I put this slide up because IPF is also interesting because it is a new disease, and actually there aren't that many new diseases in the world, perhaps leaving aside infection. And this is a learned unit in Edinburgh in the UK and very typical of the 1970s, where big institutions were reporting case series of people with IPF, and they've got 96 cases they have found over 20 years. In Nottingham, we are a smaller centre than Edinburgh, and I did a quick count before I came. At the moment, we got 450 on our books. So there's been a dramatic change in IPF for reasons that we do not understand. I put a quick slide in because this highlights a big problem for us, which is how to diagnose IPF and what is it. And these are the current guidelines we use. They're the American and European and joint Japanese guidelines from 2011. And they need updating. And part of the reason we're not updating them is we're not, if we're honest, quite sure what to do. So if we want to diagnose IPF, the first thing is to try and exclude anything else we know is a cause of this disease, such as asbestos exposure or drug exposure or connective tissue disease. So we try and get rid of them. Then we hope that you see a very typical pattern on the CT scan. I've already shown you the CTs, and we heavily rely on the CTs in these people, and there's careful definition of what that CT should look like. Honeycombing, predominantly basal, and so on. And if you haven't got a CT scan, what we have done traditionally is to proceed to surgical lung biopsy. So the summary of the current guidelines as they stand is if it looks like IPF on the scan and you can't find any other causes, we'll call it IPF. If not, you need a surgical biopsy. And actually it occurred to us that we don't know, we had no idea how many surgical biopsies we did for interstitial lung disease. We guessed it was less than 10% of patients, because a lot of these people are old. And we had no idea how safe this procedure was. And in a little audit in our hospital, we had 1 death out of about 100 cases. So we decided to look in 2 data sets around that, and the first is the US inpatient data sample, a data set which I thoroughly recommend if anybody wants to do a study. It's cheap, it's very good, it's very large, and allows you to look at in-hospital mortality. And what we found was that overall, people who are having biopsies for interstitial lung disease in the States, 2% of them will die in hospital. This is not a treatment, this is a diagnostic procedure. 2% of them will die. And if you are younger and you have no comorbidity, you're less likely to die. But if you are male and you're over 74 and you've got comorbidity, 1 in 10 die as a result of this diagnostic procedure. And we then repeated the study in the UK. It took us longer because the bureaucracy around getting data in the UK are harder than the States, and found almost identical results. Other data are coming out from Canada and elsewhere in Europe suggesting that there's a 2% mortality with this diagnostic procedure. And so there's been a massive reduction in this procedure around the world. And this is going to limit, when you start thinking about diabetes and lung disease in general, you're going to need to be careful about lung biopsy, and you may need to shift your efforts more towards thinking about imaging. It also means that if you're thinking about IPF diagnoses for epidemiological studies, they're going to be simpler than your clinical definitions. But that's not to say that doesn't have its use. And if I can get you to think back of Dolan Hill, which is one of the early case control studies for lung cancer, that had no histological confirmation in that at all. It was just where the physician said they had lung cancer. And yet that remains one of the cornerstones of our epidemiological research. So moving forward, if we're going to look at this disease in detail, and if we're going to unpick what it is about diabetes, it's not going to be like studying kidneys. We are not going to be able to do lots of lung biopsies. So how common is it? And if you want to attract interest in any disease, the first thing you've got to do is try and work out how common it is and whether it's worth looking at. What is the burden of this disease? And this is one of the early studies, was by David Coultas, who is an epidemiologist who at the time was working in New Mexico, who just did a population-based survey in one county in New Mexico. And he found a prevalence of about 17 per 100,000, with a median survival of about 5 years. So it gives an incidence of about 3 per 100,000. And we did a number of studies looking at death certificates and GP data in the UK in the early 90s and found similar sorts of results. But as we have studied it over the years, as I alluded to earlier, there is something quite bizarre going on in IPF which we do not understand. And this is death certificate recording from the UK. And you can see that if you went back to the late 60s, we had about 600 deaths a year from IPF in a population of about 55 million. And this has rocketed. Now, we have done validation studies of death certificates at 2 different times, once in the early 90s and once in about 2012. And what we know from death certificates is that about a quarter of people with IPF don't get it on their death certificate. So this is an underestimate of the true number of people with it. This is not because of CT scanning, because CT scanning comes in around here. And this is not because of an age of the population, because these are all age adjusted. And this is the incidence taken from GP data, from NHS GP data, which is a good source of epidemiological data in the UK. And again, over a shorter time period, we can see a big increase in the age-adjusted incidence of this condition. And we do not understand the reasons for this. Who are these people? Well, they're predominantly older people. The mean age of diagnosis is 74, which is bang on the same age of lung cancer in the UK. About 2/3 of them are men, and on average they survive about 3 years. There's a lot of variation. We have a lot of people who die quite quickly. We have some who have very slowly progressive disease. So we get around 5,000 cases a year in the UK, and when I'm pitching this in a public health setting, what I would say to you is it's a similar disease in terms of burden and prognosis to something like ovarian cancer. And it needs to be treated with the sort of gravity that ovarian cancer is treated with. So could it be recognition of milder cases? So whenever you see a large increase in the incidence of the disease, first thing you've got to say is, am I just spotting it more than I used to? A classic example of this being hemochromatosis, where the very big increase in incidence was driven by recognition of milder disease. So the way to work this out is actually over time, are we seeing an improvement in the survival? And the bottom line is, no, not really. I've got 4 calendar periods here. See, in the very early one, the median survival was only 2.6 years. It's not really changed greatly after that. And our clinical studies back in the early 90s again found a similar median survival. But that's not to say this is not disease ascertainment. But if this is, what it means is we are not yet getting to the point where we're picking up the milder cases, so there's a lot more of it to come. The one data set I'm trying to get my hands on to sort this out is the British doctors cohort, because it is ascertainment and we're just recognising more and more people. I can accept that in the general population, but as doctors we've always investigated each other. So if we can see an increase in doctors, then that's likely to be more of a true increase. So moving on to what might cause this disease, these are a number of risk factors, really pretty much for any respiratory disease. Genetics and familial disease, yes, definitely. Traditionally, we thought only 1 to 2% of cases might be due to this, and we know that there are families who have odd interstitial lung disease. We have recognised from GWAS studies some genes, but they only explain a minority of cases at the moment. Smoking has a lot of varied data on. Some people find an association with smoking, some don't. I would have to say the social class relationship in this disease is very flat, and I don't think there's a major role for smoking personally. Occupational exposures we've looked at might explain cases, but not very many. Low levels of asbestos exposure. Could levels of asbestos exposure that we don't currently feel would increase your risk of lung fibrosis, could these be an important cause? And there's a study going on in the UK to look at this at the moment. Infection we've looked pretty hard at and have not found. Reflux is intriguing. Reflux is not the most glamorous of research areas, but actually there's a lot of data suggesting that reflux is important as a cause of lung fibrosis. And intriguingly, we get a number of patients who've got very one-sided disease, and a French study has shown that the people who've got one-sided disease are more likely to report reflux. And also, you've got to ask them what side they sleep on, and they may often sleep on the same side where they have more lung disease. The other thing I'm interested in is clotting, because there are a number of things which suggest that the clotting cascade is activated in people with lung fibrosis, and maybe this is important. And so we did a case control study looking at just over 200 new cases of people with lung fibrosis compared to community controls, and looked extensively at their markers of clotting. And overall, the thing that stood out was if you had a deranged clotting, largely driven by elevated factor VIII levels, you were 4 times more likely to get lung disease. And I was quite intrigued because went around the posters early on in the week, and what had never really dawned on me before is that people with diabetes have got an increased tendency to clot because their platelets are abnormal or activated. I just want to show you quickly this intriguing trial from the States. Around about the same time, we wanted to do a trial of warfarin, but we couldn't get funding for it, which is why we did a case control study looking at clotting. In America, they cracked on and did the warfarin study, and this is a very well-designed trial, and it was aimed to put in 256 people, randomised double-blinded controlled trial that was stopped early by the Data Safety Monitoring Committee. For 2 reasons. Firstly, that it was no way was it going to meet its primary outcome, so they didn't feel it was worth recruiting more people. But also, worryingly, there were 14 deaths in the warfarin group compared to the control group. And your knee-jerk reaction will be, yeah, warfarin, older people, this is not necessarily a safe drug, maybe they're dying of bleeding events. But they weren't. In the warfarin group, 14 deaths, 11 were respiratory and 2 were cardiovascular. And what we recognise in idiopathic pulmonary fibrosis is this is not a disease which goes down in a linear fashion. The natural history of this disease is that you will go along in a stable condition, and then for reasons that are not clear, you have an acute deterioration. We call them acute exacerbations, but that's not a great term because they don't get better. You go along, you have an acute deterioration, then you go along again, you have another acute deterioration. And these were more common in the people who were on warfarin. So this study was designed to see whether warfarin was a good treatment for IPF, and it wasn't. But the intriguing bit for the etiology of this disease is that warfarin made these people worse, and we don't understand why. And actually, then we went back to look in our study, and if you looked at the time of diagnosis in our study, you were nearly 3 times as likely to be on warfarin if you had IPF than if you were a control. And in any other setting, you would think that this is a adverse drug event. So now I'd like to move on to comorbidities, and I'm going to start with some of the more obvious ones, and that's lung cancer. And I don't think anyone in the respiratory world would argue that people with IPF have got a big increased risk of lung cancer. About 5% of them will get this at some point in their life. A number of people have shown this. It happens whether you're a smoker or you're not. But the risks are multiplicative. So if you're 10 times more likely to get lung cancer if you've got IPF, and 20 times if you're a smoker, you're 200 times if you're a smoker with IPF. So these are the patients that are in desperate need of smoking cessation. I would also say that radiotherapy and surgery can be tricky, rather as they can, as I alluded to, for lung biopsy, that we worry that if you operate on these lungs or give them radiotherapy, they will have an acute deterioration. And my time on the wards last Christmas was rather dominated by 2 patients, one of whom had had a biopsy, having been sent from somewhere else, in her late 40s for lung fibrosis, who ended up dying, and another patient who'd had a small tumour with a wedge resection, so a pretty minor surgical procedure to remove this small peripheral tumour, who had IPF, who also died. So the management of these patients with lung cancer can be tricky. So cardiovascular disease, there's an increase in cardiovascular disease in IPF, and it doesn't seem to be completely explained by traditional factors. This is a study just following up people over time after their diagnosis of IPF, and the thing that stands out is a big increase in acute coronary syndrome, an increase in deep vein thrombosis, and in stroke to a lesser degree. And if you look at studies so when you go for a lung transplant, everybody pretty much will have an angiography done. People with IPF are more likely to have coronary artery disease than people with COPD, even though people with COPD are the smokers. And this is just showing the cumulative incidence plot of acute coronary syndrome over time. looking not dissimilar to a number of ones I've seen for diabetes this week. So the increased risk in heart disease in people with IPF is about the same as diabetes. Clotting and deep vein thrombosis, you do get an increased risk in. And this is a study where they've looked at what is written on your death certificate in the USA, and they've compared people with IPF to the general population and found a 30% increased risk in thromboembolic disease. And that may be, you think, okay, well, people with IPF are not very mobile, they're almost bound to have increased clotting. But if you then compare it to people with COPD, the effects are very similar. And interesting for me, if you compare it to people with lung cancer, and we know people with lung cancer are at a big increased risk of clotting disease, it's still higher in people with IPF. I alluded to reflux a bit earlier, and I just wanted to show you this study because this is a really neat study. And what they have done here is just take the CTs. Everybody with lung disease pretty much will get a CT scan these days. And what they do is to just take consecutive CT scans of people with lung fibrosis, IPF, about 100 of them, some with COPD and some with asthma, and they just looked at the prevalence simply of hiatus hernia. And they did this judged by radiologists. They said blind, but actually how can you blind the diagnosis here, because we know this person's clearly got basal lung fibrosis. But what they found was a 39% prevalence of hiatus hernia in people with IPF, and much higher than COPD and asthma. And along with diabetes and clotting, reflux is the other thing that really needs unpicking in this disease. So I'm now going to move on to endocrine diseases, and I thought I would try and cast my net a little bit wider than just diabetes, and I found this study on thyroid disease. It's the only study I can find on thyroid disease, so I think we may do a master's project on thyroid disease. And it's a case control study, 196 people with IPF. Matched with people with COPD. Interestingly, this study, and it's one of the few, did not find an association with diabetes, but did find a big increased risk in thyroid disease. And interestingly, it also found that if you had thyroid disease, your survival with IPF was worse. So now moving on to diabetes, and I'm grateful to the talk from Stefan before me. I've always kind of had a vague interest in diabetes and lung fibrosis, but when I gave this talk I thought I'd better do a PubMed search and go through this properly. So I put in idiopathic pulmonary fibrosis and diabetes into PubMed, and you get 64 publications. And in fact I did it on Friday before I came this time, and there's one more, but it's not a particularly relevant one. And this is about as close you can get to a Google whack in the medical world as anything. It just shows you that really nobody is looking at this problem. And there's this nice review by Yang et al. In Diabetes Journal in 2011. And it argues on many areas, some of which you've heard from Stefan already, which is diabetes affect many organs and the lung's not well studied. And I would say, I mean, diabetes, from my medical school memory, affects small vessels, and there's a hell of a lot of small vessels in the lung. There are, as you've seen earlier, associations between diabetes and lung function, which will need unpicking on several levels. And as you've also seen, pathologically, there's an increase in the thickness of the epithelial capillary basal lamina in people with diabetes. So you would expect them to have more mismatch. You would expect them to have reduced transfer factor. And there are animal models also which suggest that diabetes can affect your lungs. And you've seen these results already. This is one of the first studies in this area. This is a case control study from Japan, 65 cases of IPF and 184 controls. Several interesting things in this study. First, they find a very strong association with smoking. And this is way off the scale to anything that other people have shown. Most people with smoking find odds ratios of under 2 if they find anything at all. So this is very marked and different. They find a very strong association with diabetes and the reverse with hyperlipidemia, which in my simple metabolic mind I don't fully understand. So we went on and used UK GP data. So in the UK, all of us are registered with primary care doctor. They're our first point of call for any medical intervention or medical contact. And for about 10% of the UK, we download these data and we can use them for research. They're anonymised. So they're a good source for getting epidemiological data. And this is a study of 920 cases and 3,500 controls, and we were chasing a number of diagnosed hypotheses. We're chasing diabetes, we're chasing gout and reflux. And interestingly, what we found for diabetes was an increased risk, particularly in those that were on insulin, and we found similar things with ulcer drugs. A lot of our patients had prednisolone before, reflecting the fact that if people, community doctors, see people who are breathless and they don't quite know what to do, they'll often put them on steroids. So in our multivariate analysis, the two things that remained and stood out were insulin and ulcer drugs, and we also repeated the analysis excluding anyone that had prednisolone before, because obviously that can give you diabetes and upset your stomach, and the effects remain. You've seen some of these data from Moises Selman before. This is a case control study, and Moises is one of the leading American researchers in IPF, and this was very much set up as a case control study to sort out the causes of IPF. 97 cases, 560 controls, and they looked at a lot of exposures in this study. They looked at a lot of things, and they validated their diagnosis of diabetes by looking at fasting blood glucose. And I just put this slide up just to show they were looking at a lot of different diagnoses in this study, and pretty much nothing came up. Pretty much nothing, except type 2 diabetes, being a man, and perhaps being a former smoker. And in their adjusted analyses, these were the things that stood out. And by far the strongest risk factor for IPF in this study in Mexico, having looked at a whole load of other stuff, is diabetes. Quick couple of other studies. This is from Korea. This is looking, we know, as I said before, people with IPF have got more coronary artery disease than people without IPF. And this was just a study looking at people with IPF in Korea. And the only reason I show it is another study which finds an association with diabetes. And you almost begin to get wary now of studies of IPF that don't show this association. And interestingly, this is a further study from Korea, and the reason I've shown this is the implication of this study is that people with diabetes have got aspects of their scan with more honeycombing, which we would regard as the markers of poor prognosis, which fits in quite well with this Danish cohort of 121 cases, which were looking to see not just what causes the disease, but what might affect its outcome. And one of the biggest prognostic factors in this study was a diagnosis of diabetes. Now, obviously, we need to know what diabetes will be life-limiting to a degree in the general population, but this is quite a big impact and comes back to a point that Stefan was making, actually, which is in treating this disease, we do have drugs, they don't work well, they slow the progression of the disease, they don't improve the patients. So actually, one thing we've not focused on is a more aggressive management of their diabetes. Interestingly, anticoagulation treatment is also a bad prognostic marker. So just for my last slide, I wanted to just mention metformin, because when I was at medical school, metformin was a not very good drug for diabetes, which was said to work by making people feel ill, and therefore they ate less. And then it seems to become a wonder drug for many different uses. And perhaps not surprisingly, therefore, people have looked in observational data on its impact on IPF. And they looked at 3 of the big trials that have been done for nintedanib and pirfenidone, which is our 2 drugs for IPF, in the placebo limb. So bear in mind, these are people who are deemed well enough to go into clinical trial, if that makes sense. These aren't extremely sick people. 11% of them are on metformin. So there's a lot of diabetes in this population. And what they found was it didn't have any impact on the survival, and possibly a more rapid decline. Now, whether that's because this identifies as just a marker for diabetes or not is not clear. So I wouldn't make much of this, but just to point out that people have looked at it. So just in my summary slide, what I'd like to say is IPF is a lot more common than people think. So think IPF, it's about the same as ovarian cancer. Survival is poor, Lung cancer and coronary artery disease are major comorbidities. Reflux and clotting needs unpicking. We can't get away from the fact that diabetes is more common in people with IPF, and we don't really understand why. There's also hints of evidence that people with diabetes may have worse survival and worse CT appearances. And it just raises a possibility that if you could treat diabetes or prevent diabetes, this will be the first time you could actually prevent IPF or potentially make IPF better. So I'd like to thank you for coming to listen about respiratory medicine at your diabetes conference. And I'll stop there. Thank you very much.